Good morning, everyone. Welcome to today's webinar on strategies to build support for primary prevention and opioid use reduction in the construction industry. I'm Chris Kane, Executive Director at CPWR, the Center for Construction Research and Training. I have the great honor to introduce Dr. John Howard, Director of NIOSH and Administrator of the World Trade Center Health Program for the U.S. Department of Health and Human Services, who will give us some opening remarks. Dr. Howard?
Well, thank you very much, and welcome everybody to the workshop. Thanks for joining us today. Before the COVID-19 pandemic arrived, we in the United States were already facing another very critical public health crisis, rising rates of drug overdoses and other harms from substance abuse disorders, chiefly involving opioids, but also involving other drugs and alcohol. Deaths from drug overdoses are a leading cause of death in our nation. From 1999 to 2017, more than 700,000 people died from a drug overdose. And what's very interesting for us today is 95% of these victims were working age. Some industries and occupations, as we know from research, are especially hard hit by the opioid epidemic. Construction workers, as we all know, are dramatically increased in terms of risk for the opioid crisis. Their working conditions, their risks for injuries, the insecurity of their work, the long hours, the lack of paid sick leave, all place them in grave peril for opioid misuse, for an opioid use disorder, and unfortunately for opioid overdose fatalities. Construction is an industry that also generates a high number of musculoskeletal injuries that we all know cause chronic pain, often spinal pain and low back pain, which are all too often treated with opioids. Surveillance studies have shown that opioid overdose rates for construction workers are 6 to 7 times the rate for all other occupations. The COVID-19 virus and the social and economic challenges arising from it have had particularly harmful impacts on individuals struggling with substance use disorders, leading some experts to call it a perfect storm, and that's not a compliment to the situation. As of July 2020, the American Medical Association reports that more than 35 states are already experiencing increases in opioid-related mortality since the COVID-19 pandemic began. Job loss, increased stress, social isolation, harmful drug use patterns, and disruptions in healthcare and support services can all increase the risks in this setting. For us in NIOSH, we are definitely committed to addressing the drug overdose and crisis head-on, and we rely on partners like CPWR. The work of CPWR, together with North American trades unions and other partners to combat the opioid crisis, is now, I think, more important than ever, and together we can face this challenge. So I invite you to Google NIOSH opioids to find out more about the data, NIOSH research, and our toolkits and guidance documents. From first responder resources to industry-specific insights, you'll find valuable information for workers and employers. Our newest addition to the site focuses on the concept of workplace-supported recovery. These programs can holistically address the opioid issue by helping organizations build a culture of prevention and support for those at risk for substance use disorders. Today's workshop takes an important upstream look at the crisis and moves us from the all too common focus on what's called tertiary prevention back to looking squarely at primary prevention. How can we improve the work of the construction trades to prevent painful work, halt that first injury and the first use of opioids, improve employment arrangements and benefits, and communicate with workers and employers to prevent the risks associated with opioids. Those are all questions that this workshop is designed to address. At NIOSH, we applaud the work of CPWR, one of our greatest partners, and we look forward to continuing our long-standing and very productive relationship. Substance use disorders, especially opioid use disorders, may be devastating. They create chronic conditions, but they can be treated, and people can recover and move on to more productive and fulfilling lives. Perhaps most importantly, they can also be prevented. And amid the unprecedented times of challenge that we're in, we can all, and I urge all of us here, to take steps to make prevention our primary goal. So I want to thank you, Chris, for inviting me to the workshop, and I wish everybody at the workshop great success. Enjoy the workshop. Thank you, Chris.
Thank you, Dr. Howard. I really appreciate your remarks as well as your continuing support of the work we're trying to do with the construction industry to address this hazard. It means an awful lot. And I'm going to just say a few more words and then introduce our main event. So Dr. Howard did mention that we have a disproportionate risk in construction of overdose death, and we at CPWR and the building trades, our goal is to prevent these deaths and prevent them in multiple ways, and one of the ways is to move it upstream, address the injuries that cause pain, but also interrupt the cycle of opioid prescriptions. We wanted to explore how to better communicate about that primary prevention, as we like to refer to it, and the addressing of injuries, the addressing of pain. And so we're really excited to work with the Frameworks Institute. Obviously, we are very dedicated to supporting all construction workers, no matter where they are in their journey, but if we can work as far upstream as we can prevent disorders, opioid use disorders, we hope. So Framework Institute is a nonprofit research organization that uses rigorous social science methods to study how people understand social issues. They develop evidence-based techniques that help researchers, advocates, and practitioners explain those issues more effectively. We ask them to examine similar social issues to recommend how to apply the findings to opioid challenges among construction workers that we face today. I'm really pleased to introduce Jennifer Nichols and Clara Gibbons from Frameworks, who will walk us through their findings. Jennifer Nichols is the Director of Research and Interpretation Application Unit at the Frameworks Institute, and Clara Gibbons is a Senior Strategist in the Research, Interpretation, and Applications Unit at Frameworks. So following their presentations, we'll have time for some questions and answers, so please type your questions in the chat box, and I'll come back to moderate. So now I'm going to turn it over to you, Jennifer and Clara. Thank you.
Thank you so much, Chris, and thank you, Dr. Howard, for your opening remarks, too. I will point out as we go along some of the framing strategies that Dr. Howard used in his opening remarks as we share them with you. So I'm Jen. I'm joined here today by Clara, and I'm just on camera now for a quick second to say hello, but we're going to go off camera so we don't distract you with our while we present. I'm going to share my slides, so I'll be sharing my screen, and let me do that. Jess, I'm not seeing my, are they there?
Yeah, no, I see Jennifer Nichols is starting to share content. maybe stop sharing and try to do it again.
Okay. Let's try again.
Oh, I just saw something. I think it might just be taking a minute with everyone. There we go.
You can see it great. Yeah, we did practice before we got on the webinar. I promise we did, but technology has a way of foiling our best efforts. So I want to begin with this quote by American philosopher Richard Rorty, who wrote, "A talent for speaking differently rather than arguing well is the chief instrument of cultural change." And I think that's as good a way as any to introduce the work that we do at Frameworks, because our mission is to help the nonprofit sector, the public sector, researchers, scientists, advocates who are trying to move social policy forward by helping them to communicate more effectively with the public in order to build support for the policies they're trying to advance. We do this on a lot of different issues at Frameworks. We're probably best known for the work that we've done on early childhood development and translating brain science with the Harvard University Center on the Developing Child. But our work extends across a range of issues, including social determinants of health, environmental health, human services, housing and housing inequities, aging and ageism and demographic change and what that means for our communities. I'll talk more about our research as we go through the webinar. This is what we've got in store for you in the next hour or so. We'll spend a little bit of time thinking about why bother framing at all, why have we devoted so much of our time to thinking about framing, and then we'll zero in on the CPWR project itself, talk about the goals of the project, the methods we used, and the findings, our recommendations to you on how to frame these issues surrounding opioid use in the construction industry. And then we'll take a closer look with the time that we have at just a few of the key takeaways. There's a whole brief that is available on our website. I believe the center has shared it among their mailing list too, I think. And so you can dive in more deeply through the report if you're interested in that. And then we'll have time for discussion at the end. So first, why frame? In a nutshell, the reason to frame is because framing solves a problem. And the best way to maybe introduce that problem to you is to put you through a little simulation of an experiment that was first performed in 1944 by two psychologists, two researchers named Hyder and Simmel, who were trying to understand how people come to draw conclusions about an issue. So in the original experiment, they asked people to watch a short film, and I'm going to play that film for you. It's silent, it's about 90 seconds long, and I just want you to watch the film and then in the chat box, record what you see. So pay attention to whatever you notice and go ahead and write down what you see. So if you saw a story emerge, go ahead and talk about it in the chat box, just really briefly. What was the story you saw? And Clara, if you could help me out by sharing what some of the responses are, that would be great.
Sure. Chris says conflict.
Okay, a story about conflict. Anyone else see a story emerge? I've shared this with many different groups and have seen lots of different stories show up. Things like stories about bullying, stories about love triangles. Claire, what else do we have?
I see Anthony says the two triangles were assisting each other at first and then helping the ball. Marilyn says breaking the limitations, the box.
Okay, breaking out of the box. The circle is a ball. The two triangles are using a ball. Anything else?
Yes, we're starting to get a lot of responses. The door was getting in the way, eventually opened up room to be more accessible.
Okay, so that line moving back and forth, there's a door.
Conflict and confrontation.
Okay,
support and help.
Okay, yeah, some unity there too, maybe some solidarity.
Pursuit.
Yep, there was some chasing, it looked like.
Controlling pressures, a depiction of aggression.
Yes, okay, so aggression, maybe the big triangle seemed aggressive.
Someone being harassed and someone trying to help.
Okay, so again, a version of conflict. So someone coming to the rescue, someone else is being picked on or harassed. Right. I've presented this at so many different venues and have gotten a lot of different responses. I remember one memorable response was in winter. I was presenting up in Connecticut, and a parent who was clearly just tired of the snow said it's a parent stuck at home with kids on a snow day and really at her wit's end.
Okay.
So there's lots of different stories. Lots of different stories that emerge in this. But the interesting thing about this is that what we really saw on that screen were two-dimensional shapes moving around. The box can look like a structure, and that line looks maybe like a door. But beyond that, we put in lots and lots of information that wasn't actually there. We made a story out of it. We assigned characters. We talked about conflict. So there are emotions. There was antagonism. There are motives. So there's a lot that we added to this message. And the reason that matters, the reason this identifies the problem in framing is that we think in story, and it is just our brain's programming to put things into a message that may not be there in order to help us make that message make sense. And that means for our messages, if we don't put the right information in, our audiences are going to fill in the gaps for us. And what they fill in the gaps with is anybody's guess. It may not be what you want them to fill in the gaps with. The reason we do this, the reason our brains work this way, is because we all rely on assumptions in order to process information quickly. So it's actually a normal cognitive process. Our brains do this so that we can really efficiently make sense of and interpret all the stimuli and all the information that our senses are taking in all day long. So it's a normal process, but the problem is that as we build up these automatic, taken for granted assumptions about how the world works and use them as mental shortcuts to process information really quickly and kind of fill in the gaps, the things that we've missed or the things we don't understand, our perceptions are actually often inaccurate. and they can block us from engaging more deeply with an issue. So that becomes a problem if you're a communicator trying to share a message with people who may not be experts on the issue that you're trying to communicate with them about, because then you don't really know if they're hearing what you want them to hear and what they may be filling in. So I want to share an example with you of some of the shared assumptions that we discovered in our research on how people think about health and public health. And what we found is that there are some top of mind assumptions people use to make sense when you of health and health issues that are really rooted in assumptions that health is a choice that we make as individuals, and in thinking about public health, that public services are actually mostly charity for those who aren't self-sufficient. Those are really widely held assumptions, just quick mental shortcuts that we use to process information about those issues. So I'm going to play a quick clip for you from some peer discourse sessions we ran to across groups working in different sectors, education, health, business, housing, to get a sense of how the public in general thinks about these issues. So as you listen to the video, pay attention to the kinds of ideas that come up again and again.
I'm curious how you would define health.
Well, health is health for the absence of disease.
How is your general body behaving? And
When you're not feeling right, when you're not feeling like you were or think you are, and you think it's time that somebody needs to take a look.
How are you feeling when you wake up in the morning? Do you want to lay back down, or do you want to get up and go running?
Not being encumbered or restricted from a normal lifestyle.
When I think health here.
I would say access to healthcare.
So access to healthcare, so clinics and hospitals.
Having the access to health services.
Access to some place that will help you live well.
What would you say shapes how healthy or unhealthy someone is?
Your diet.
Eating the right types of foods.
Working out and making sure you're making healthier decisions while you're eating.
Diet and exercise and sleep.
It's common sense. You go to the doctor.
A lot of people put off going to the doctor.
Your company can offer you the best health care in the world, but if you never go to the doctor or you avoid your problems, then...
Exposures to bad environments, places that some people can afford, are places that really you have to decide, your life is in danger being there sometimes.
And a lot of your lower income communities are food deserts, and you don't have good full service grocery stores.
Landfills, people are getting high
that would be a
doses of
problem.
carcinogenics because it's leaching into the water.
If I were to ask you what is public health, how do you think you would answer that question?
It's not an easy question to answer. A lot of doctors have masters in public health, but I'm not sure what it entails.
If you work in the public health profession, aren't you concerned with policy or something?
When I think of public health, first thing that comes to mind is health care for the poor.
Dealing with the healthcare needs of the indigent.
Certain facilities that are operated and funded by the government.
Okay, so what you can hear in all of these clips is snippets of the truth, of an accurate picture of what health is and what public health is, but there's a lot missing too, and that gets short-circuited by our need to process information really quickly. But if your top of mind association with health is that it's about your choices, your lifestyle choices, it makes it hard for you to see things like social determinants and how those things can affect your health. So you heard a little bit in the video from the housing experts in particular, talking about environments. Those folks in that particular session were a little more clued into the ways external factors, context, and environments can influence health. But by and large, what we heard were sort of truncated definitions of all of the kinds of factors that go into building and promoting good health. Okay, so that is an example of how cultural models work to inhibit people's understanding of an issue. So we know as communicators that telling a story is important. We've looked at how we make up stories through the circle triangle film example. We fill those things in, but as communicators, we really need to be asking, what is the story we're telling doing? Is it helping people think more expansively about an issue, or is it actually short-circuiting their ability to engage more critically with the issue? And so framing helps us solve that problem by guiding us to make intentional, strategic choices about what to say, what to emphasize, and what not to say in order to shape people's understanding of an issue in a way that helps them really dig in more deeply and see the issue more like experts do. So at Frameworks, we talk about all the different kinds of choices that go into a message, things from what values you appeal to, so what is your emotional appeal, to how you use numbers and data, to the kinds of examples you use, the visuals you choose, the tone of your message. All of those things together compose a message frame and have implications for how your audience hears and interprets what you're saying. At Frameworks, in order to figure out what framing strategies work best for talking about a particular issue, how we can kind of navigate around the limitations of those widely shared assumptions people have about social issues, we use a series of empirical research methods that taken together we call strategic frame analysis. So it's a multi-method process that we put any candidate framing strategy through to test it to see how well it works to build people's understanding. And we can take questions at the end of the session. If you'd like to know more about our research, we explain a bit more about that as we go along too. But it begins with a deep dive into what experts want to communicate and what it is the public really understands about the issue and where the gaps are between expert understanding and public understanding, so we can then begin to design and test strategies that we can use to fill in those gaps and tell a more complete story that will bring public's understanding along with those of experts. So in this particular instance, and the research that we did to try to find strategies for communicating more effectively about the social determinants of health, we tested a number of strategies and landed on one. It's the metaphor of community foundations of health as a way of explaining the social determinants that go into people's health outcomes. So I'm going to play a short video for you now. You can hear that metaphor at work and compare it to the video you just heard to note the differences in how people are thinking about health once they've been exposed to this particular metaphor.
Our focus is the building of a foundation, what public health represents.
Building the foundation is the key to anything.
Just as a building needs a strong foundation to last for a long time, so does a healthy lifestyle needs a strong foundation.
The house, the foundation, or the pillars where you've got the supports that keep the whole structure up.
If you don't have a foundation, there's nothing else to build on.
And the reason that's important is to have strong communities in all facets and all areas.
And the solid foundation consists of the academic achievement, affordable housing, healthcare, and employment opportunities.
Building a foundation that supports safe and affordable housing with access to quality healthcare and employment opportunities.
Public health is that profession that can help build that foundation.
They construct the building blocks to help the public understand what a healthy community means and what it should look like.
There's certain people that are going to take care of certain facets within that community. And
community buy-in to make that support structure strong so that the people above it can go out and work together and in community.
So if any one of those aspects are not perfectly planned for and implemented, you're going to have a shaky building.
So in that clip, you can hear people taking that idea of the foundation or building a strong building and applying it to all the many social, contextual, environmental factors that go into health. And they've moved away from focusing so deeply on things like lifestyle choice, right, or food or exercise or whether you use substances and really expanded their thinking both of what leads to good health and also the role of public health. They had an answer for it through the use of that metaphor. Over time, if you disseminate an effective framing strategy, you can make social change possible. And that's really at the core of our work. We work to help a field of practice communicate more effectively in order to change public discourse change the way people think about an issue. And in doing that, we can build support for better social policies among the public, among policymakers, in the media, and so on. So I'll give you an example here from our aging work. For the last few years, as we've completed our work on how to communicate more effectively about aging and ageism and demographic change, the advocates and experts we've worked with have really been pushing a new story about aging out into the world to displace more dominant assumptions about older people as vulnerable, language that is less helpful to supporting the role and contributions of older Americans. So we've helped them displace the sympathy frame, that idea that older people are vulnerable and we need to feel sorry for them, and it's our duty to try to take care of them because they're so frail, and instead help them push out a story that's really about the ways in which ageism is a justice issue, and we need to address it as a justice issue. What we've seen is that the advocates have taken that language and put it into editorials. They've done a lot of work within their field, within their own communications, but then also in engaging with media discourse to push out a new way of thinking about aging and the language we use to talk about it. Over time, we're seeing changes even in something like Allure magazine, realizing that terms like anti-aging aren't doing older people any favors. They're not helpful. They're really rooted in our cultural ageism. And we've seen policies shift too to an understanding that we need to support age-friendly policies, and that if we can build age-friendly communities, those are really communities that work for all of us. So you can see the strategy in play. You talk differently, that leads to thinking differently, and that leads ultimately to different policies. So that's really at the core of what we want to do with CPWR and all of its stakeholders. And I'm going to ask Claire now to walk us through the goals and methods and findings of the work that we've done with CPWR over the last several months.
Great, thank you, Jen. Well, hopefully Jen has convinced you of the importance of framing and of the power of an effective framing strategy. So I'm going to go ahead and give you an overview of how we have developed the framing strategy that we're proposing for the CPWR project specifically. And to do that, we started off with 3 questions to answer for ourselves in developing the strategy. So first, we wanted to know what experts need the public to understand about opioid use and the construction industry. We are not experts in this field. You all are. And so we needed to know what the public needs to understand in order to support the sorts of solutions that you all want to see get put in place. And next, we needed to know how the field is currently communicating about opioid use in the construction industry, about opioid use disorder, and see, based on what we know, based on research that we've conducted, the likely effectiveness of those communication strategies. And then finally, we need to know what research-tested framing strategies can improve the public's understanding of these issues and foster support for evidence-based solutions. And so I'm going to just take you through a bit more in detail to show you what we found. So first, we reviewed many documents, a lot of literature, to see what the key points that we kept seeing come up again and again that experts needed the public to understand. So first, we saw that one of the most core concepts is that construction workers are at a high risk for opioid use disorder, higher than the general public, because of workplace conditions, the treatment practices of doctors, lack of financial support, of paid sick leave, and a financial need often to return to work prematurely. We saw that experts really want the public to know that opioid use disorder doesn't just affect individual workers, but that it affects families, it affects communities, it affects employers, and it affects the entire construction industry. And we saw the solutions that were being proposed were primary and secondary prevention solutions. So better workplace safety practices, more robust sick leave policies, alternative pain management options. All of these are ways of reducing opioid use disorder. And finally, in order for those solutions to be put in place, many stakeholders need to be brought to the table, including labor unions. So once we understood what needed to be communicated to the public, what needs to be communicated to the public, we reviewed our research. So we have research, as Jen was mentioning, on all sorts of different issue areas. And for this project, we drew on a number of different projects. So we looked at our research on substance use prevention, public health, labor unions, mental health, environmental health, and also patient safety. These were the sort of, all right, well, this makes sense that if we are going to be talking about substance use prevention and preventing of substance use disorder, we look at those things. We also looked at our research on issues like criminal justice, aging, and oral health. And that's because we knew that the key concept here was translating the science of prevention, of framing the importance of prevention. And these are fields that are doing the same thing. And what we find again and again in all of the issues that we study is that prevention is a really, really difficult thing to communicate about. So Jen, if you can go to the next slide. Prevention is difficult to talk about, and it is difficult for the public to think about. So we know how the public thinks about these different issues, right? And just like you all came up with stories when you saw that triangles and circle video, people are bringing their own understanding of issues to bear when they are thinking about things like the construction workforce and opioid use disorder and opioid use. So we saw, we identified which of the dominant patterns in public thinking were most likely to be barriers to building support for primary and secondary prevention. And what we found were these models, and I'll take you through some of them. We'll talk a bit more about some of them later on. But first, there are some models of health they pose barriers to communicating effectively about prevention. And the first one of these is that health is the absence of illness. So people, and you saw this in that clip that Jen showed you, when people think about health, they think about it as the absence of something, the absence of an injury, the absence of an illness. And so that makes it very difficult to communicate about things that build health, that promote health, because it's always being thought of in these negative terms. And when you ask people what public health is, they're still thinking about healthcare. So just the phrase public health is not necessarily going to improve understanding of who is responsible, of what needs to be done, because when people hear public health, they're still thinking healthcare, they're thinking medical care. And when people are thinking about what does affect health, they're thinking largely about lifestyle choices, about individual lifestyle choices like diet, like exercise, like whether or not people are going to the doctor. And those are all deeply rooted in individual behaviors, which makes it hard to build support for structural changes, for structural interventions, and to any sort of prevention solution beyond education. So you might be able to educate someone about the risks of something, about the risks of taking opioids for pain management, for example. So education might be a solution that people can think about. But beyond that, it's very difficult to get at these deeper structural changes because they're just not on the public's radar. And instead, when people are thinking about things like opioid use disorder, the sort of first solution that people can think about is treatment, not prevention. So people can think about treating opioid use disorder, but it's much harder for them to think about what sort of changes might be made in order to prevent it from happening in the first place. Part of that is because of this model that we call stuff happens. Injuries are going to happen. Workplaces are going to be unsafe. And there's this deep sense of fatalism around prevention and all sorts of issues, but here as well, that there's anything that can actually be done. There is a black box around public health, again, so it is difficult to explain what sort of interventions, what interventions could look like. And there is a lack of understanding of what unions can do. When people think about unions, they're likely to think about unions negotiating pay, but it's much more difficult to communicate about how unions can do other things, like work to improve workplace safety, for example, because that's just, again, not on the public's radar. Jen, if you could go to the next slide. Great. Okay, so once we knew what sort of barriers there were in public thinking, we were able to identify the framing strategies that we've seen work to overcome those barriers. So these fill in knowledge gaps when people don't understand things, and they also avoid cueing some of the unhelpful thinking, things like that idea of fatalism, that nothing can be done, or the idea that an individual's lifestyle choices are the sole determinant of their health outcomes. And so here's what we identified. We saw that it would be very important to carefully link causes and consequences to support, to show what the root causes of opioid use disorder are at a structural level. Because if people understand how the causes can be structural, then they can better, they're more likely to support structural solutions. We identified a metaphor that we'll talk about a bit later to help explain prevention and to show how and why prevention is so important. We identified a value that we had found be effective in messaging to industry professionals around the importance of public health. Choosing concrete examples. It is difficult, again, there's a lot of fatalism around the efficacy of solutions. It's difficult for people to believe that solutions can actually be effective. And showing people concrete examples of what those solutions can look like will increase support. Providing context for data and for unfamiliar concepts. This is really just remembering that you are not your audience, and that a statistic might mean something to you and not necessarily mean the same thing to your audience. Explicitly naming who or what is responsible for the problem and for taking action. This is to overcome that idea that this is an issue that is entirely about an individual's lifestyle choices. Explicitly naming other people as responsible, other actions, other systems as responsible is necessary to move past that model. And finally, emphasizing systemic solutions. Again, this is trying to get past that idea that this is entirely around an individual's behavior. And so today, in just a moment, Jen is going to walk you through 3 of these key strategies: the upstream-downstream metaphor, the value of investment, and the importance of providing context to help your audience understand any data you're presenting.
This might be a good moment just to pause and see if there are any questions in the Q&A box or the chat box that we should address before we move forward.
Yeah. Oh, okay. So here's one question that I know I can answer. This idea that Stephanie says, I somewhat disagree with the idea that we haven't focused on prevention of opioid prescribing and are too treatment focused. Opioid prescription have declined, but treatment, oh, I see. Okay, so some of these questions are about the actual policies and practices. And I think what is important for us to note right here is that this is sort of what we're saying today is that really fully explaining the role and responsibility of insurance companies, of medical care providers, explaining what needs to change and why is going to be really, really crucial to seeing the sorts of changes that you want. And we'll have more time to talk about that, but I want to make sure that Jen has plenty of time to get through these key strategies.
Okay, thanks, Clara. So we'll focus just on a few key strategies, the ones that Clara had just underlined, and we'll start with this one, the idea of using the upstream-downstream metaphor to explain prevention. In a lot of our research, what we find is that using metaphors it's a powerful way to help make complex ideas more accessible to people who aren't experts on a particular issue by comparing those ideas, the mechanisms behind them or the processes to something more familiar. So for example, in our early childhood development work, it's difficult to explain neuroscience to non-neuroscientists, but it's a lot easier to explain how brains develop if you compare it to the way houses get built. So if you use that metaphor of brains being built the way houses are, then it makes it easier for people to understand why the earliest years of life are so important to a child, because that's when you lay the foundation. It helps people understand that the materials that go into a child's early years, from education to nutrition to health to supportive relationships, all of those things are the materials that build a brain. And we know that houses made of poor materials they can be structurally unsound, that projects don't turn out as well. So by tagging familiar concepts, mapping them onto unfamiliar concepts, you can really help very quickly build people's understanding of a complicated or complex or unfamiliar topic. So Clara had run through many of the framing challenges, that those assumptions people make about an issue that can stop them from thinking a little more deeply about an issue. And upstream, downstream, when we tested it in our work for the American Public Health Association, when we were looking for strategies to help people understand social determinants and the role of prevention in shaping people's health outcomes, really that metaphor really helped tackle a few key challenges in particular. It gave people a sense of feasibility. So it moved folks away from the assumption that there's nothing we can do by helping them to see that, in fact, upstream of where we all live and work as individuals and play and enjoy life, there are things that we can do at a structural level to influence the context that surround us and the environments that surround us that shape our outcomes. It helps people understand that health is not solely the determinant of lifestyle choices, but really those social factors and environmental factors. And it helps people build a deeper appreciation for and understanding of the role of prevention in promoting health, not just remediating problems. The interesting thing about the upstream-downstream metaphor is that it's something that's already widely used within the health field, but at the time that we tested this, it wasn't being used in public discourse with the public, with policymakers, in the media. It was a metaphor that we came across in our interviews with experts who wanted to share with us kind of the key concepts they wanted to communicate with the public. And we heard that metaphor come up again and again, but it wasn't showing up in the media content analyses we did in any of our conversations with the public. So we tested it to see if that metaphor, which was just an internal one being used by the field, could actually translate to an effective strategy for talking with people not working on health-related issues or workforce safety issues or environmental health issues, and it worked really well. I heard Dr. Howard use it in his opening remarks. He talked about working upstream to promote primary prevention solutions, and I noted that was really appreciative of the way he built that metaphor so readily into his opening comments. So the idea here really is reminding people that there are forces outside of our individual control, but that are within our control as a society or as a field of practice or at a structural or systems level that can influence how our health is shaped and what our outcomes are. I'm going to play just a very quick clip of some persistence trials in which we asked people to use the upstream downstream metaphor to think about prevention, and you can hear them kind of playing with it, mulling it over, thinking about how forces flow down to us, and we can do work upstream to affect those forces.
What do you take from that? What do you understand that paragraph to be about?
In this metaphor, we have a number of rivers that are flowing.
Anything that happens upstream, whether it be good or bad, it's going to eventually filter down.
Right. There are problems that we create in one area that seem to run off and affect the rest of us.
We are all a part of this environment. If you want to think of this metaphor as us being, the lake.
Things that happen upstream as they bring their problems down from the river to the lake, as an example, creates some problems for those of us who live around the lake.
These streams are coming into one major body, and a little bit from here, a little bit from there, and all in terms of a negative sense, it all adds up.
In listening to this clip, what you can hear are examples of people thinking about the different kinds of preventive measures that can be taken to stop problems from happening in the first place, to slow them down before they become worse. And there's language they're using to talk about health as something outside of our total individual control, which is a big move forward from the really deep-seated beliefs that the public has that health is entirely within our control, and a lot of the language we use around health really enforces that or reinforces that deeply held belief. If you think about people fighting a disease, for example, they lost the battle with their illness. That sort of language, which is so pervasive, really kind of just reinforces for people the idea that everything is within our control. And a metaphor like this can help us understand how at a policy level we really can make a difference and stop those problems. So if you take that metaphor and apply it to the issue of primary prevention within the construction workforce, it's a way of helping all stakeholders understand the role of workplace safety. Clara said earlier that we at Frameworks are not experts on this issue. We're not experts on workplace safety. We're not experts on public health. We are communications researchers. And I've learned so much from working with CPWR about these two issues, that workplace safety, it makes total sense once I had it explained to me. I thought, oh, of course, there's a real relationship there between what we do to prevent injuries in the first place, but that's not something that's readily apparent to those of us who aren't experts like all of you are working on these issues. And so upstream, downstream can help people understand the connection between things that don't seem on the surface to be related, like what your workplace culture is and how seriously employers and labor unions work to enforce workplace safety, and what kinds of healthcare options are available to people who are likely to get injured on the job. To make those connections to this other problem that in our media coverage often seems discrete and separate and unrelated, which is the opioid epidemic. So using a metaphor like that can help make visible the connections between cause and consequence that are often invisible to those of us who don't have the deep knowledge you do about your field of practice. Just a quick example of what it would look like to apply a metaphor like this to a communication. So on the green side of the screen, you see a statement here about the construction industry having high injury rates compared to other workforce populations. And then it finishes up, since use of opioids has led to addiction and overdose deaths, it's important for workers to understand the risks and alternatives. That is true. But the challenge here is that if you're trying to help people understand what kinds of primary prevention solutions are available, this message puts the onus on workers themselves to do whatever they need to do to keep themselves safe. So that's a form of health individualism that doesn't build people's support for the kinds of policy solutions or practices or workplace safety changes that need to be enacted at a much broader level and a higher level than that of the individual workers. So if you take the upstream downstream metaphor and apply that to this message, you see that you can instead shift people's attention away from worker responsibility, and which they already get, they have a deep understanding of that, to something they don't really understand as well. So here's the same sentence at the top, and then it moves away from workers understanding risks and alternatives to other kinds of solutions. These cascading effects put construction workers at a higher risk. So cascading effects is a version of upstream, downstream. It's that idea of things, rolling forward. Improving workplace health and safety policies can act as a dam upstream that prevents injuries and the risk of opioid use disorder from developing downstream. So using the metaphor makes the idea of primary prevention really easy to imagine by giving people something concrete to attach to it. Everybody knows what a dam looks like and what it can do. Everybody understands the concept of water running downstream and carrying things with it, and what cascading effects look like. So there are just a lot of different ways in which you can use metaphor creatively. Cascading effects, a dam upstream, prevent injuries from developing downstream. So you can be creative in the way you apply it. The second thing I want to share with you, the second key takeaway, is this idea of appealing to the value of investment, specifically when you are trying to bring on board employers within the construction industry who have a role to play and are in a position to enforce better workplace safety practices that can really make a big dent in the number of injuries that construction workers experience. Appealing to a tested value works in, especially at the start of a message, to connect to people through an emotional appeal to something they believe in. So you're not diving right into a message with facts and figures and here's the problem. You're taking time to explain to them why the issue matters to them, what's at stake for them. It invites people in to a conversation who might otherwise dismiss it as irrelevant or of no benefit to them. Appealing to a value helps lay down the stakes by showing people what we stand to gain or lose by taking action or not taking action. And it engages people's deeper listening skills because you've built that bridge between them and their beliefs and the information that you're about to share. We tested the value of investment specifically to see how it would help business leaders, industry professionals, the private sector, think more deeply about the value of investing in health-related issues, health-related resources, developing programs and policies that can promote health rather than just remediate it down the line when it becomes a bigger problem. So reminding people of their shared commitment to using resources wisely, to reducing inefficiencies, to reducing unnecessary costs, can get employers, can get industry professionals listening more closely to what you have to say about how primary prevention may require some resources to really implement, but the return on that investment is worth it. This is just a clip of some business leaders who are using the value of investment, thinking about it, and applying it to thinking about primary prevention solutions. You can hear how they're taking that up and thinking differently about it than they were in earlier videos.
Ignore a problem, it's only going to get bigger, bigger, and bigger. The little molehills here will turn into a mountain of a molehill. You take care of it and tackle an issue now, it will not cost so much down the road.
So there's less lack of attendance and productivity by providing what they need. So to collaborate with them will save money overall for the company.
So here what you hear them talking about is the ways in which employers, business, the private sector can work with experts on public health, experts on workplace safety to embed primary prevention strategies, to use resources in ways that promote health and set a good foundation for that. In practice, you might think about changing a tweet like this. So this says, attention trades, did you know substance use disorders cost the economy $442 billion every year. Construction workers are at greater risk than other workforce populations because of high injury rates. So that's sharing some information, but there's nothing in here to connect that information to something that employers in the trades can do. So there's no sense of engagement here in terms of shared responsibility. So you can use the value of investment to build that shared responsibility. Here's the same tweet, slightly rewritten, starts out the same way, and then it moves to invest in workplace safety to reduce injuries and help your workers get support and treatment so they can stay healthy and stay on the job. It's the right thing to do, and it can help your bottom line. So it's tying that investment into both a social, a community, a cultural investment, as well as an economic investment to really call people to action. And then finally, I'll just share a little bit about how you might rethink the ways you're using data and other unfamiliar concepts in your communications to reach out to audiences who may not have the familiarity that you do with the data that you're sharing. There is a tendency among advocates, and I would say just about every issue area that we work in, to believe that if you just show people the data, they'll see what you see. They'll understand the problem, the size of it, or what to do about it, or how important it is that we act now and prioritize that problem. But what we find is that that doesn't really work that way. So as much as we may be attached as researchers to our data, the public is much less likely to take those numbers and think of them, interpret them, use them to build their own understanding in the way that you do. So I'll pause here just to say, I want to share with you now a clip from our adolescent substance use prevention work. This is a field that was really across the board, just diving headfirst into communications that put big, scary numbers up front and thought that that is the way to compel people to care about adolescent substance use and how to prevent it. And so we put that to the test. We took some of their communications that were really numbers heavy, that just relied on numbers to tell a story about the issue and compel people to care about it, and asked regular folks to read some of those messages and then interpret what those messages mean or what their key takeaways were. So the video that you're about to see first shows a short statistic about use among high school kids of substances rather, and then asks people in the room to make sense of that. And what the message is trying to say is this is a big problem. We need to do something about it because the numbers are shocking. So listen to how the public responds to these shocking numbers.
I would say in my 12th grade year, this would have been pretty accurate.
Really?
Yeah.
Mine too, and I'm older.
The 80% doesn't necessarily surprise me because it could be a one-time use.
I think it's about, prestige in your group. What makes you cool?
And they've been trying, like I said, but this stuff is plentiful. You can try, it's up to the kids that want to really leave it alone. It's easy to get, it's plentiful.
You can have every program in the book, you can have every government program, Christian program, outreach program idea. It doesn't matter whether it's schooling or alcohol or drug or any problem with society. It really boils down to if it ain't fixed at home, nobody else is going to fix that problem.
So what we heard here was that strategy backfiring spectacularly. People instead came to the conclusion that 80%, it's normal. It was probably higher when I was a kid because we were, really wild and crazy. And it's normal for kids to experiment with substances. So it's no big deal. And if it is a problem, well, it's a problem that's rooted in parenting. And so some parents just haven't done a good job. But there's nothing we can do about that. No government program, you heard him say, no program that's going to solve for bad parenting. So all of the communications priorities of the advocates, which was this is a problem and we need policies and programs in place, early interventions, promotive policies, all of those communications goals were left unmet by the communications they were putting out when they made numbers the core of the story. So there's some things we can do, and chief among them is to add some interpretive cues and some guidance to help people make sense of numbers the way you want them to understand them. So here's an example on the green side of the screen. In 2017, more than 72,000 people died in the U.S. from an overdose, over 49,000 of which involved an opioid. So it's a big number. One study showed that more than half of those who died had suffered at least one job-related injury. Without interpretive cues, there's not a lot here to help people understand who's at fault for the job-related injuries, what could have been done to prevent that. These numbers are really big, so remember what Clara had said about fatalism, the sense that like, we can't stop bad things from happening. Stuff happens. So this message is likely to cue up a lot of those pre-existing assumptions people have that will stop them from being able to think more expansively about what solutions actually are available to us. So if you add a little bit of context, if you point people to a solution, you can wrap your data points in interpretive cues that really help people kind of come along with you in the direction you want them to go. So here's the same data point, but it's just wrapped at the beginning and the end with a little bit of context. Workplace safety practices decrease injuries, which in turn decreases opioid use and overdose. So right there, you've helped people already begin to think about what the issue is. It's that we need better primary prevention solutions, including workplace safety. And then down at the bottom, again, the same middle section, but the end sentence, job-related injuries can be prevented when employers provide safe workplaces. So you're just really honing in on who's responsible, who are the stakeholders here, who's in a position to make a difference here. It's not only the individual worker, it really is about thinking about things we can do at a broader level to make a difference in these numbers. And I'll leave you with one final point about using data. Here you have a data point. The tobacco industry spends $12.5 billion a year promoting smoking. Well, I don't know about you, but I am not a billionaire. And so even though I know that's a lot of money, I don't really know what that means in practice. Compared to what? How does that compare to how much the auto industry spends in a year promoting driving? Is it the same? Is it normal? Should I be shocked by that number? Is it not that much? So putting numbers into a relationship, giving them some context, can really help people understand your data a little more accurately. So here's a comparison, a relationship, that same data point. The tobacco industry spends more money promoting smoking in a week than the entire federal government spends on preventing smoking in a year. That now helps me understand exactly how much money is being pumped into advertising a defective product to the public in ways that I couldn't get from just knowing it was $12.5 billion, because we can see here the size of the effort compared to what resources we have to defeat that effort. And then it helps me understand the scope of the problem, what we're dealing with, and what we need to do in order to address the issue more concretely. So with that, I'm going to ask if anybody has any questions. We're getting near the end of our time together. Anything in the chat box?
Yeah, there's been a few coming in. This is Chris. I was going to pull out a couple. Some of the questions were really related to prescriptions and doctors prescribing and health insurance companies potentially facilitating the development of a substance use disorder. But I kind of want to table those, because this conversation is about, you know, the primary prevention, not the secondary or tertiary, in the model that we follow, for the public health model we talk about for opioids. So there was a couple questions and an observation I wanted to pull out. I know we're getting close to the end of the time, and this one question is meant to put you on the spot a little bit to see how you do. But one comment or commentary that came in was it's really commenting on the video clip used to show the importance of recognizing structural change to promote health. It presents employment job opportunities as an essential part of the solution. So thinking about, you know, what does this mean in most public health professionals see work as a solution? How do we maybe use that kind of thought to talk about construction work, good jobs, part of the solution, while we're also trying to frame things in an injury prevention style? I don't know if you have any reaction to this kind of thoughtful comment.
Mm-hmm. I appreciate that comment. I think that those two things go hand in hand, and I think one of the roles of labor unions in particular, but anybody working in the space of workforce development and workplace safety, has to help people understand that good jobs simply aren't only about pay and benefits. They're also about health, about knowing that you can go to your job and come home and still enjoy good health and be safe. Nobody should be scared that you know face the likelihood or a higher risk of injury because of their job, and the nature of some jobs makes that to some degree inevitable. However, I think the pandemic and what we're seeing with frontline workers right now has actually opened an opportunity for us to talk about work and what a good job is, and help people understand that it goes, yes, it's about being able to earn a living wage. It's about being able to support yourself and your family. It's about thriving communities, but it's also about health, because if you don't have that through your job, if you can't be safe at work, then all those other things are also jeopardized. So I see those things going really nicely together.
Okay, great. One other really may not be simple question, but it's short. Who is the public in the terms of this presentation? When we talked about trying to frame the public's view of this or that, I don't know if you wanted to respond to that.
Yeah, that's a terrific question. So one of the goals that we have in framing is to reach the widest swath of the population as possible with a strategy that works to build their understanding of an issue. And so when we conduct our research, we're looking at, it varies. Like our adolescent substance use or adolescent development work actually included in the public young people, but typically for most of our projects, we're looking at people who are 18 or older, so defined as adults, and we look for in our large-scale quantitative work, nationally representative populations. In smaller sample sizes that are too small to be nationally representative, we look for a sample from a third-party agency we work with that is diverse in terms of age, race, gender, education, income, geographic location, party affiliation, or political spectrum. I think those are the income level. So those are the things that we look forward to when we're looking for a sample of the public. The last thing I'll say about that is that we find that policymakers and media are just as likely to share the same cultural models as the public because in part they're so deeply immersed in the kinds of dominant cultural stories that shape our understanding of issues like health individualism, for example.
If I would also just like to add to that to say that I think these models, as Jen was just saying, policymakers are just as likely, people in the media are just as likely to share these models, but I think we all are maybe more or less likely to use these models maybe in different situations, or maybe just one of them is an automatic thought and then we can say, oh wait, but actually, right? So these ideas of individualism, or of fatalism, maybe especially, even people who are used to thinking about these issues all the time, who are thinking about structural solutions, the model of fatalism you might be more or less likely to use it, depending on the day, depending on the context. So these are models that are available to everyone in our culture, and depending on the situation, we might be more or less likely to use them. So I know that's maybe not a specific answer to the question of who the public is, but I think it is important to think of us in some way as kind of all being a part of that public.
Mm-hmm. Okay. One question that just came in is, how do you address the strong emotions that people have around opioids and the quote-unquote responsibility for addictions? Feelings often rooted in both stigma and their own personal experience of the damaging behaviors resulting from opioid addiction. And I asked this question thinking that a lot of what you talked about got at this from a health standpoint, the personal responsibility, but I don't know if you just had anything else to add as a result of this specific question.
Mm-hmm. So I think what I can add is that our research and other framing research has found that when you directly address someone's prevailing viewpoint, and that prevailing viewpoint is at odds with the thing you want them to think about, you actually end up reinforcing that viewpoint instead of helping them maybe see things from a different perspective. So for example, if you're communicating with an audience that has a deep commitment to the idea of personal responsibility and its relationship to substance use, talking about how personal responsibility is part of it and also this other thing has to be part of it can actually just confirm for them their commitment to personal responsibility, and then they kind of shut down and don't hear everything else because of this confirmation bias we have, where we listen for the information that agrees with what we already believe to be true or know to be true, and then everything else kind of gets filtered out. So I would say that a good strategy is really to prioritize your argument and affirm your argument and your position, rather than trying to persuade people that their position isn't helpful to the kinds of changes you want to see.
That's a great answer. I appreciate that. I'm going to kind of close with this one, and this is the one that might put you on the spot a little bit. A recent study came out that found that A construction worker is more likely to receive an opioid when they are injured on the job than the same injury in someone else that happens off the job. How might we talk about that? Or is that a teaser for tomorrow?
Well, that's a really, it's a good question, and I don't know if I have a good answer for it, because I think that the underlying question is, how do you talk about class bias? How do you talk about race bias? How do you talk about kind of pre-existing assumptions that may be operative in a health professional's decision to prescribe an opioid to this person but not that person? And there are so many things that go into that, from patient advocacy to health professionals training in thinking about how our biases affect our decisions and our choices. And I don't know if I have a good short response, but it's something that I do think you need to be aware of. And I guess if I were thinking about how to frame a conversation about that, I would fall back on the idea of linking causes to consequences and making those connections explicit. In our aging research, we did some testing to see if explaining how implicit bias works in the ways we think about aging and older people, if explaining that could actually change people's perceptions, and found that it was possible to reduce people's kind of automatic assumptions about an older person or about older people generally, if you first explain to them that there is a problem in the ways we think about aging, and that can affect how we treat people. So there might be something there. Claire, I don't know if you want to add anything to that.
No, I would just emphasize that and really say in general, when you have a question, how do I frame issue X? If you want to rely on something that I think is pretty reliable, the answer is really yes, to explain the root causes of something and link those root causes to a structural solution, and really walk people through the cause and effect process to help them understand why a particular solution is important or why a problem is happening, and just really taking the time to do that. Jen introduced the upstream downstream metaphor and the value of investment, and these are great tools that you can use, and there's not always a metaphor for every single issue, and those metaphors are not silver bullets. They need to be combined with explanation. So if you're ever thinking about how to communicate about something and you aren't sure what the right metaphor is, I think it's sort of a safe bet often that explaining something as deeply as possible is the answer.
Great, thank you. And just, I think it's time to wrap up again. We're over our time limit, and really appreciate Nyash. I see Dr. Chuzwood still on the call. Appreciate your support in this, and thank you to Jennifer and Clara. I don't know if you had any closing remarks, but I did want to just note we do have a workshop that follows on to this seminar portion that's going to occur tomorrow, specifically for people who are communicators about primary prevention and about this issue. And if you haven't registered yet, please reach out to me or to Jessica if it's something that you think you're a fit for. But it's not a public workshop, so we'd really, we have a limited amount of space. And with that, Jen or Clara, if you have any closing remarks?
We'll just leave you with this quote from James Baldwin, who I think says it makes an excellent point, not about framing, but one that easily applies to framing, which is that the world changes according to the way people see it. And if you can alter even by a millimeter the way people look at reality, then you can change the world. And I think that changing the way the field communicates about these issues can have an enormous impact on the kinds of solutions that are supported and are made more readily available. So we can have a real impact both on the construction workforce specifically and more broadly on the opioid use crisis in this country. Thank you so much for your time, everyone. We appreciate it.
Thank you very much for helping us out, and thank you for everybody who's participated in this webinar today. Have a great day.